Hello, my name is Matthew Ricardo and I'm a physician assistant here at the Pittsburgh VA. I'm excited to discuss Pittsburgh's initial experience with robotic bronchoscopy. Many lung nodules are suspicious for cancer and would benefit from biopsies for treatment planning. Some nodules have been deemed too difficult to biopsy based on size or location. Robotic assisted bronchoscopy with electromagnetic navigation aims to improve the diagnosis of these nodules and other lung nodules alike. The diagnosis of pulmonary nodules has evolved over the last decade. However, multiple limitations continue to exist. Fiber optic bronchoscopy is limited to sampling centrally located lung nodules. Bronchoscopy, in conjunction with electromagnetic navigation, sought to improve this and has allowed surgeons to access more peripheral lung nodules. However, it does not offer direct visualization of many peripheral targets, but rather uses a 3D rendered CT scan to navigate to the target. Robotic bronchoscopy allows surgeons to easily and directly visualize central and peripheral lung nodules. In this case, Dr. Dupar was able to biopsy a 8 mm lung nodule deep within the left upper lobe of the lung. A CT scan is used to create a 3D rendered map. The robotic camera drives down the trachea, turning into the left mainstem, passing the secondary and tertiary carinas, and the endobronchial lesion was identified. Multiple biopsies were taken, and a diagnosis of non-small cell lung cancer was reported. The specimen contained sufficient tissue for immunohistochemical evaluation and other studies. This case is just one of multiple cases in our initial 24 patient experience where robotics aided in the diagnosis of a challenging lung nodule. Furthermore, diagnosis can also be coupled with staging procedures including EBUS and mediastinoscopy, which may decrease patient treatment times. In our initial 24 patients, lung nodules ranged between 8 mm and 7 centimeters. Once a planning CT scan was created using a standardized protocol, 83% of the nodules had a positive bronchus sign, or in other words, had a computer-generated route exactly adjacent to the target, increasing the operator's confidence that a representative sample was obtained. And most importantly, we had no immediate or 30-day adverse events reported. Amongst the nodules biopsied, 58% were identified as being malignant, 16% were atypical or suspicious for carcinoma, one of which was later resected and was positive for carcinoma. 5 were considered benign, such as in the case of 2 nodules that were identified as hamartomas, and 1 nodule did not yield sufficient tissue for diagnosis. Future applications, including therapeutic ablation and injectable therapies, are currently in development, along with simulated training experiences for our residents here at the Pittsburgh VA. So in conclusion, robotic bronchoscopy has been a safe and useful tool in the diagnosis of lung nodules and has assisted in treatment decision making.